right. Now moving on, Dr. Christian Mende graduated from the University of Heidelberg School of Medicine, Heidelberg, Germany. He completed his internal medicine residency at Tucson Hospital in Tucson, Arizona. He was then a research fellow at the NIH and Peter Brigham Hospital and Harvard Medical School in Boston. He is not only a specialist in clinical hypertension, but is also a charter member of the American Society of Hypertension. And since 1998, he's been a clinical professor of medicine at University of California, San Diego, and Scripps Hospital in San Diego, California. So it's with great pleasure that I introduce to you Dr. Christian Mende.
Okay. Well, good morning. I would want to thank Dr. Khan again for inviting me to come back here. And matter of fact, I always told my wife how wonderful writing was. So last summer we actually came here for 3 days for a mini vacation to tour the area. So okay, what I'd like to do today is to go ahead and talk about hypertension update. After we had years of no guidelines, now we have something like 7 or 8 guidelines in the last year, and some of them are confusing, and we're not done with it, and within a month or two we'll get new guidelines. And I'll just get into this, why we are at this dilemma right now to really trying to find out what is really the blood pressure for our patients. So this is my disclosure, so none of this will have any bearing on the discussion. Just to give you an overview, basically about 1 out of 3 after age 20 have hypertension, and it is always thought to be genetic. The genes probably play a role at most about 30%. The key risk factor for hypertension is actually age. So by the time you turn 60, you have a 50% chance of hypertension. That's 1 out of 2, very depressing. And even if you exercise, I mean, I have marathon runners who turn 65 and they're suddenly hypertensive. So if you're overweight or obese and you smoke and you don't do anything else, you may be hypertensive at age 19. So this is clearly for the average population. But if you turn 90, you have an incidence of 90%. So that pretty much tells you the incidence. The control rates are, if they're less than 140 over 90, are over 50% very clearly. We will get some new government data soon, but the CDC about 2 years ago gave us the very good news that we almost at goal in 2 out of 3 patients, which is not perfect. And that's, by the way, the best control rate in the world. And the incidence of hypertension in the US is not worse, despite of our obesity. So it's the same in Europe, the same in Japan, the same in South America. So it's not that much of an issue. It's the same issue all over. So just to remind you, we're not treating a number. We're treating really to prevent target organ damage, and this is just something you're very aware of. That again, that means that if you have uncontrolled hypertension, so don't get the idea that if your blood pressure was 160 over 100 and now it's down to 130 over 80, that you're going to develop microalbuminuria or CKD, or you have a great risk for TIAs or strokes. So a left ventricular hypertrophy. So you need to put this in perspective. So if you talk about complications of hypertension, it is predominantly uncontrolled hypertension. So that needs to be said. So if we then look at something which is actually new because of this national concern about Alzheimer's disease, and we knew for a long time that if you had recurrent TIAs or and in particular had small strokes, that you will lose gigabytes and eventually have a reduction of your brain function. But what we didn't know is that even without strokes, that you're at risk for Alzheimer's. And here's a study which was done in Hawaii, and you can see that if your pressure was less than 140 basically versus over 160, that your risk of dementia, mainly from Alzheimer, was 4 times greater. So this is actually interesting. Now the study was a ginkgo study which showed that ginkgo is absolutely useless. So any one of you who's taking it is kidding herself or himself. But what it also showed very nicely is that if you were hypertensive and you did take any antihypertensive drug, irrespective actually for most classes you took, you reduced your risk by about half. So which is again nice to know. And something which the nephrologists knew for a while is that if you have proteinuria, that means you got 300, 400 or more milligrams of protein in the urine, even if you had perfect renal function, that there was a higher degree of dementia and loss of cognitive function. And what the answer to this is we don't know. We do know that if you develop microalbuminuria, even without diabetes, just because you have uncontrolled hypertension or you have metabolic syndrome, you will actually have essentially endothelial dysfunction. So this may well be connecting to that aspect. So very quickly, to insult you, but I need to tell you that even when I see a physician, at times I'm being put on the examining table. Of course, I say nothing, and your legs are swinging freely, and you have no back support. And if you take that pressure, and you then sit the person in a chair with both feet on the floor and the back supported, the difference may be 10 millimeters systolic. You can do this on Monday when you get back to the office. So we basically really need to take, everybody knows, excuse me, about the cuff size and the repeating the readings, and we're getting pretty much to a triple approach now. And I'll show you the data that the first reading is just really to get it out of the way, and you don't have to wait 5 minutes, just wait a little bit and take a second and third one. And what is coming very strongly into play over and over very much this year is the home blood pressure readings. You know, the diabetics take their glucose frequently at home. We give somebody a blood pressure medication and tell them see you in 3 months. That's just not good enough. And now you can buy gadgets like Omron, OMRON, and again, I have no stock in the company, and you can buy it at Walmart or Costco. I have no stock interest in either one of the two. And you can get the gadgets for less than $30. And if you can take home readings and can be instructed, and they're much more reliable because it's also recommended a couple months ago from the U.S. Preventive Task Force that we should obtain 2 readings and ideally confirm the readings at home. So I think we need to get to involve all of our patients with taking their pressures at home. And here are the data. Again, how many readings are reliable. And basically, the biggest study is from Kaiser. This is the one at the bottom. That if you take 3 readings and you discard the first one and you average out 2 and 3, 1/3 of the patients who you thought had hypertension because you only took 1 or 2 readings actually turn out to be normotensive. So this is an important aspect because they would not require therapy. These are office readings. So now about what are the facts of home versus office. The correlation in 5-year data of stroke, CVAs, CHF, any event from hypertension are 2 to 1 in favor of the home. So the home blood pressure reading is twice as reliable as a predictor of events than the office. In addition, we now find out that about 8 to 10% of our patients feel so elated, let's use the word, when they see you, that they become normotensive. But the minute they leave the office, they become hypertensive. And I don't understand it, but it's really recognized, and we call this masked hypertension. We know from the cardiology studies that they do develop LVH. It really is an important, is hypertensive period. But why they're normotensive in the office, we don't know. And if you are not making the diagnosis, you can't treat them. So basically, by just obtaining a couple out of the office blood pressure readings, you will actually catch the 8% or so who do have that. Now here's just something for all of us to say, what's the proof that taking the readings once or twice a week at home indeed has any additional benefits? It actually leads to better care because the patients do see their pressures elevated. We did a little study in our office. The number of patients who didn't show up for follow-up was much smaller in the people who take their own pressure, so they get involved in their care. So don't let them take the blood pressure, 5 times a day. Then your fax machine is going to be full, and your email is full, and the engineers come in. They have it meaned out on graphs. So then it becomes a disease. So the blood pressure taking. So don't allow them to do that. So, but at least you have this. And again, if you have home readings, you know what white coat syndrome is. Here's the definition. If you're normotensive at home and you're hypertensive in the office, that's about up to 30% of the people. The older you get, the more likely you are having white coat syndrome. But something new from a couple of weeks ago caught my eye from Dr. Weber, who's on all the hypertensive committees from JNC 5 to 7 and 8, and he'll be on the new committee for our guidelines in the next couple of months. And basically, what he's sort of re-examined, he said, if you really look at people who have white coat syndrome, they're hypertensive, like 150 in the office and 130 at home, you should, as a healthcare provider, take another look at them. Because many of them have an overactive sympathetic system, so their pulses are up. They may have hyperlipidemia. The cardiologist probably should see them and put them on a treadmill, and they will have 220 systolic when you exercise them. And that's not really good because you want them to exercise. And they maybe even should have a cardiac echo because they may have early LVH. So what I'm saying that we actually should not just say, well, you're normotensive out of the office because they may be more hypertensive at times with stress than you think, and we need to take a little closer look. And then Dr. Weber said, what's the issue? If somebody has hypertension with exercise, and exercise is like 3 times a week, that person should be on a medication, ideally like an ACE inhibitor at bedtime, that won't drop his pressure excessively, but actually prevent the exercise-induced hypertension. So then, after all of this, so what is the ideal blood pressure? And I'm telling you right now, even this is my area of expertise, we really don't know what the ideal blood pressure is. We're still guessing, and we'll give you some idea as we go on. So if you look at over 40,000 patients and look at all the studies on Target and Accord, etc., they sort of averaged out and said, well, if you're down to about 135 over 85 and you have hypertension, you do fairly well. So I thought, let me just pull out of the literature what actually does a 10 millimeter over 5 reduction do to you if you have hypertension at any age. Let's say from age 20 till age 75, 80, what does it do for you? Well, these are for the people who don't want to take a pill. You can tell them that you reduce their stroke by at least half, you reduce their coronary artery disease by close to half, and even in diabetics, you reduce the CVAs by 26%. So this is a pretty impressive tabulation. So then let's look at the diabetics, because they're a little bit more complicated. So if they are hypertensive, you again have quite benefits. And by the way, any study you look at, hypertension has the best reduction of events for strokes. So that has been true for decades. But interesting enough, at the bottom, even if you had a pressure of 135 and you have protein in your urine with diabetes, and I lower you by 10%, at 10 millimeters, I get an additional 17% reduction. The same is true for retinopathy. So diabetics who have albuminuria or retinopathy, you may want to consider even lower their pressure from the 135s to 125s. And I'll get to some of the guidelines in a moment. But at least gives you a little bit idea what the reduction of blood pressure is doing. So here's the trial, which actually will, I think, in some ways, totally make us rethink all what guidelines we have had out this far. So this trial, published in England Journal last year, did something very unusual. They took over 9,000 patients, and they said, well, we're going to treat you close to 120, and the other group stays to less than 140. And then they included people with CKD, so the EGFR, about almost 30% were less than 60. And look at this, they had 75-year-olds, almost 1/3 were 75 or older, and 10-year risk of 15%. So this was not a healthy population, but they excluded diabetes and polycystic kidney disease, and they excluded prior CVAs. So what pressure did they actually attain? So what their goal is and what they got to is a little different. So they were able to get down to 121 in half of the group, and the other group was walking around with 136. And there was 15 millimeters difference. However, here comes the big difference. This was the first trial ever where all the readings were obtained unobserved. So what they did is to put the patient in the chair, back support, leg support, put the automatic Omron on there, put it on a 5-minute delay, walked out of the room. I don't know whether they played beautiful music or whatever. And they had to take 3 readings. threw the first reading out and then averaged reading 2 and 3. So when this came out, everybody says, oh my God, all of our blood pressure should be down to 120. And then people looked at studies and said, okay, what happens if you stay in the room, whether you're a nurse or physician or any healthcare provider, and your pressure stayed 10 to 15 millimeters higher by staying in the room. So now we need to look at something completely different. Do we get out of the room? How many rooms do you need where you put people in there for 15 minutes in your office? So what I'm trying to do is that 121 really is more like a 131. So you actually have to go up the results from this trial by 10 points to compare. So the 121 was the 131 and the 136 was the 146. So we are not quite ready yet to say, well, everybody should go down to 121 because, again, this was unobserved. So there's a difference of 10 millimeters. So you'll see a lot of discussions of this. But what the outcome was with that pressure was impressive, 25% composite output. If you look at 42% reduction of CV mortality. And so this was a very impressive trial showing that 15 millimeters of blood pressure, let's say the true pressure was 146 versus 146 versus 131 was very impressive. And interesting enough is there was no difference in both groups in worsening or affecting renal function. And I'll get to this in a moment, that we are going to become very, very specific if you have hypertension with reduced renal function versus hypertension with proteinuria versus hypertension with diabetes. So we can't just say this is the ideal blood pressure for anybody. So we need to truly individualize. So this is my society, and 2013 they'll come out along with the American College of Cardiology and the AHA, American Heart Association. They'll come out with a combined guideline early this year, later on. So here are their old goals. I think that they're probably going to come down. I predict they'll come down probably closer to 5 to 10 millimeters minimum. So, and the same for all across. So basically, we'll probably see a lowering of goals by about 10 millimeters across the board because of sprint. And here's something which I am going to really emphasize to you is the diabetic guidelines were not that much different, but here they say less than 130 over 80 for younger patients, and it's your decision whether somebody is young or not. So basically it means if you can tolerate the pressure well. But one thing which is evolving is the circadian treatment of hypertension, and I'll show you data that if you take an ACE inhibitor or calcium channel blocker or both, or even a 12.5 diuretic, which you should be able to take at 6, 7 o'clock in the evenings without too much nocturia. 25 will ruin your sleep, but it will actually lead to much better blood pressure control. So for the diabetics officially right now, we have the rule that if you're on one drug for hypertension, you got to take it at bedtime. And if you're on two, at least one of the two should be taken at bedtime. And I'll show you the data in a second. Here it is. So if you have diabetes, and let's say you take your 40 milligram lisinopril at bedtime, and the other group for 5 years takes the 40 milligram lisinopril in the morning. And if you look at what happens, that the ones who take it at bedtime have a lower nocturnal blood pressure, and upon waking up, which is the highest time of our pressure, have about a 5, 6, 7 millimeter lower blood pressure, and do not develop excessive low blood pressure. But if you look at the events in 5 years, there are 12% fewer strokes, 12% fewer MIs and deaths. So for taking the same medicine, just HS, is a huge difference. And then you look at people who have less than 60% of kidney function, and you can see that the same mechanism, and here they followed them for 7 years, that you had suddenly 14% fewer events. So it does make a lot of sense, and there are more and more articles coming out about what we call chronotherapy. Same is true, taking your statin HS makes, it's better to, and there are actually data to show that if you take your aspirin at bedtime, your GI bleedings or gastric erosions are a lot less than in the morning. So we are beginning to find out that it does make sense, particularly for the antihypertensive drugs, to be taken at least 1 HS or even 2 or 3 HS. Okay, one look about the obesity hypertension association. If you look at secondary causes of hypertension, we always look about pheochromocytoma, which I've seen 3 in my lifetime. Other, renal artery stenosis, which I've seen a lot. But basically, if you really look at the number one secondary cause, it is obesity. And here you see the numbers from the US, 2 out of 3 overweight, 1/3 have a BMI over 30. And you look at what happens if your BMI is over 30. 3 out of 4 have hypertension. And if you look at all hypertensives in the US, it's basically about 75 million people. If half of them have a BMI over 30. So there's actually a linear relationship. Even if you are totally normal weight, and for some reason you decide you want to lose a kilogram, which is 2.2 pounds, your systolic will go down by 1 millimeter, and if you gain 2.2 pounds, it goes up by 1 millimeter. Well, it's almost impossible to measure, but if you look at 10 pounds of weights going up and down, you see 4.5 millimeter systolic blood pressure variation. So this is the relationship. So if you ask why is hypertension is associated with obesity so frequently, and interesting enough, your renal angiotensin system is up. The fat cells produce renin, angiotensin 2. They produce leptin, particularly in females, and the leptin actually causes aldosterone increases. And the pulse rate goes up because, particularly in males, because it has central effects. And then, of course, if you are obese, you usually eat more. That means you have more salt intake. But you also have renal mechanisms which cause a release of angiotensin 2. So basically, you have an active sympathetic system and an overactive RAS system. So if you then look at any society which has anything to say about hypertension, what are the guidelines for obesity, hypertension? None. None has ever addressed options specifically directed if somebody has a BMI of 35 and is hypertensive. And so what you just heard, what makes a lot of sense is to use a RAS blocker, an ACE or an ARB, aldactone and diuretics. I just want to remind you that you can now use baby doses of aldactone and hypertension. You can use 12.5 milligrams 3 times a week. This drug has almost the 76-hour half-life. So you can use 12.5 of aldactone 3 times a week. You won't get any breast tenderness in the males or any other issues, and very little potassium issue with that low dose, and you still get benefits. So you can buy a cheap spironolactone hydrochlorothiazide 25/25, cut this in half, so you're on 12.5, and this would be a way to go. What I need to warn you about is that people who have obesity very often, because of the high sympathetic system, have an increased fasting pulse rate. And unfortunately, the only physicians who pay attention to pulse rates are the cardiologists. And if your pulse is at rest 80 and higher, with normal thyroid function and without having an anxiety attack, your blood pressure is very hard to treat with an ACE inhibitor or calcium channel blocker or what have you. You actually do very well with a beta blocker. What the problem with a beta blocker is, if you don't use a vasodilating beta blocker, like the two which are on the market, which is carvedilol and Bistolic, unfortunately, which is still not generic. But if you use carvedilol, which is generic, you will not have the risk of diabetes. So what is the risk of a patient who is obese to develop new onset diabetes on 1 year on metoprolol or 1 year on another non-vasodilating beta blocker, 1 out of 4? So we are creating, now if you have had an MI or you have severe CHF, you need to use the drugs which the studies were done. So there your concern about new onset diabetes becomes secondary. But an otherwise healthy 55-year-old who already has a fasting glucose of over 100 and has pre-diabetes, if you put him on metoprolol for hypertension, he has 1 out of 4 chance. And if you do develop the diabetes, you should stop the drug. It very often goes away. Why are these drugs causing diabetes, the non-vasodilating beta blockers? Because they're reducing blood flow to the muscle, and this is why people have cold hands and cold feet on these drugs potentially. And the muscle is the #1 organ which takes up glucose and insulin. So what you're actually doing, you're making them more insulin resistant. So by using, nebivolol, which is the bistolic, or carvedilol, you have a alpha and beta effect. You have vasodilating beta blockers. You will not reduce blood flow to the muscle. Therefore, you will not cause diabetes. So this is a very important aspect. And then, of course, if everything else fails, weight loss is wonderful, which is, as we know, very difficult to obtain. However, we have more and more drugs for weight loss. The trouble is many of the insurance companies, unfortunately, have yet realized how important it is to lose weight, and they are not covering these drugs. So what I want to do is address a couple issues with people who are difficult to treat, because that's really almost up to 1 out of 6, or 10% to 15% of the patients. So who has resistant hypertension? That's a person who's on 3 drugs, which usually is an ACE inhibitor or A or B plus a calcium channel blocker, and you need a diuretic. There's an absolute rule in hypertension. If you're on 3 drugs and you're not on a diuretic, you are on the wrong combos. Because in any combo of 3, and I see at least one a month who's on a calcium channel blocker, a beta blocker, and an ACE inhibitor, and that pressure is not going to be controlled, because these drugs cause additional salt and water retention because you lower the pressure. So you have to be on a diuretic in a combo of 3. So if you're not controlled on the combo of 3, then you have resistant hypertension. And why are we so concerned about this? Because we know that people who have resistant hypertension are at a higher risk for cardiovascular events and target organ damage. So the risk is at least 2 times higher than from the non-resistant group. So what are the issues with people who are resistant? Well, if you obtain home blood pressure readings, and somebody who's on 3 drugs, 1 out of 3 don't have resistant hypertension. So they shouldn't be getting a 4th drug. So before you reach to change your drugs or you add another drug, you ought to obtain a home blood pressure reading, which is actually, if you can do a very good pseudo-ambulatory blood pressure measurement. On a weekend, if somebody's willing to do it and doesn't work, you can take 6 readings at home. In the morning when you get up at 10 o'clock, at 2 o'clock, and if you happen to go to the John at 2 a.m., just sit on not on the John, but sit on the chair with the back supported, the legs supported, and take your blood pressure. You can get an even 2 a.m. reading. So you could actually have almost a pseudo-ambulatory blood pressure. So what's the second issue? Well, there's a German study where they analyzed your urine and your blood. They must have spent a lot of money, but they found out that only about half of the people weren't taking their drugs. And then you look at all the big US studies. What was not used when they had true resistant hypertension on a diuretic and to 2 other drugs are not controlled? You need to use aldactone. Again, and if you don't want to do workup anybody, this is the magic drug for hypertensive consultant. And again, low dose, 12.5, even 3 times a week to start with, works in many patients. So this one more time shows you if you spend a lot of money into ambulatory, 1/3 of the patients are not hypertensive. And this is the study from Belgium, almost 5,000 patients. And look at this, half of the patients stopped their drug, and they skip for 1 day, and they skip for 2 days, and they skip for 3 days. The Finns did the same study over again, and they showed triple the rate of strokes in 5 years. So even people who are taking their drug every other day, every 3rd day, actually have higher events, not surprising. But the proof is from the stroke study from Scandinavia. A couple words on stage 2 hypertension, which is over 160 over 100. If you confirm this on the outside, I mean at home, and you're still at 160 over 100 or higher, your chance of being controlled with the largest single monotherapy dose you ever use is 3%. You just won't get there. So if you clearly have 160 over 100, don't waste your time with fiddling with one drug and then 6 months later you add another drug and you don't get there. So basically we start with combination. So people say, what about the side effects? Well, if you develop a cough, it was the ACE inhibitor, and if you develop a rash, it was the thiazide. I mean, we know the side effects of most of the drugs. So what is actually becoming a very popular a combo is not ACE diuretic anymore. It's actually ACE or ARB with a calcium channel blocker. And why did we change to that? A, it is probably more powerful in many patients, but B, there was a huge study called Accomplish. I'll give you some additional data in a moment, which showed if your pressure was 140/90 on an ACE diuretic for 5 years versus 140/90 on an ACE calcium channel blocker, you had 20% fewer strokes, 20% fewer heart attacks, and 20% less loss of renal function. So you actually had superior outcomes with an identical blood pressure. And this study was actually, again, stopped prematurely. So this just to remind you that this combo of ACE or ARB with a calcium channel blocker is actually a wonderful combo. It doesn't mess up your electrolytes, your potassium, magnesium stays fine. The older gentlemen with benign prostatic hypertrophy don't have to worry about their frequent urination. So for even in African Americans who we always feel need the diuretic because they're so salt sensitive and salt resistant, that group had a large number of black patients in it. So they are very vasoconstricted. So why did the blacks do so well? Because calcium channel blockers work great in African Americans because they're vasodilating well. So this is the story behind it. So then to summarize, you see a tough patient who is on 3 drugs, including a diuretic and not controlled. First, you do a home blood pressure reading. Then second, you lean on them hard to say, are you really taking your drugs? And then you look at your schedule. Are you taking a RAS blocker, calcium channel blocker, diuretic? And being a nephrologist, to me, if you're on 3 drugs, the diuretic of choice by a mile is chlorothalidone. Why? Because I'll talk to this in a second to you. It's far superior because there are patients who are 145 to 148 on a thiazide, and I switched the 25 of hydrochlorothiazide to 25 to chlorothalidone, and the pressure is down 6, 7, 8 millimeters instead of using the 4th drug. And I'll show you the slide in a moment. So what about these patients who you have on 3 or 4 drugs and somebody said, well, did you evaluate them for aldosterone excess or did you work them up? You don't have to stop any drugs anymore. We always were taught that you have to come off everything and then your pressure is 180 for a month. You can do your aldosterone-renin ratio on anybody except for people who are on aldactone. So you don't have to take them back off, okay? Again, check for excessive salt intake. You're amazed how much salt your patients are taking. And anybody who takes an NSAID beyond 3-4 days and is on an antihypertensive drug, except for calcium channel blocker, their pressure may go up by as much as 10 millimeters. So let's say you're on an ACE inhibitor with a diuretic and you were at 130. You can come to the doctor's office and you're suddenly over 140 on your own readings at home. So my number one question always is, if you had somebody you saw for years and they always were beautifully controlled and suddenly their pressure is up by 10, 15 millimeters, number one, you go through all the list of over-the-counter NSAIDs, or you ask them, did you see your friendly orthopedist? So this is usually what I do. If you happen to be 80 and you have osteoarthritis, and your blood pressure is 150, and you say, what is the ideal drug for somebody on an NSAID? It is a calcium channel blocker. All of them, from amlodipine to thiazide, whatever you like. Why? Calcium channel blockers do not get interfered with by the NSAIDs. All other antihypertensive drugs, from diuretics to beta blockers to ACE inhibitors, you name it, their efficacy goes down by 15 to 20%. Okay? So the calcium channel blockers are the only ones. Again, if anything else fails, aldactone. So if you say, what did you get home from this discussion a month from now? Just remember one thing, aldactone. Okay, it is just the most underused drug in low doses to really control difficult to treat hypertension. So this is just one more time. I mean, make you sick of aldactone, but here we choose aldactone instead of the other drugs, and you got 4 millimeters more with the doxorubicin, you can see you get additional 4, 5, 8, 9 millimeter reduction as compared to the other drugs. Okay, so what combos should you avoid? And well, the cardiologists know beta blockers with verapamil and diltiazem can cause severe bradycardia. You also should not do something I see 3 times or 4 times a year, is people taking clonidine and a beta blocker together. And we really don't know what you're doing, because there are no data who show that there's any improvement of pressure. So you should decide whether to use a beta blocker or clonidine. You can use the clonidine intermittently, which is a great drug for getting the pressure down in the ER. If you want to use an oral medication, like 0.1 or 0.2 of clonidine is a great drug every 15 minutes or so to lower systolics if you don't want to use IV medications. But the combo of a beta blocker with clonidine, actually there have been a couple of cases reported of a rise in blood pressure. Nobody has any idea what happens. But people on the 2 drugs together really walk around like zombies. I mean, you're just centrally and peripherally blocking them, and so don't use the combo. So decide which one of the 2 you prefer. And then what we have come away from completely in hypertension is the so-called dual RAS blockade. So don't use an ACE and ARB together, because you get only more hyperkalemia and very little benefits for blood pressure, and you have more risks for a renal dysfunction. So don't combine an ACE with an ARB, and don't combine the old Tecturna Liscrin with an ACE or ARB either. But you can always combine aldactone with an ACE and ARB, but then you need to watch potassium levels. So you need to, at least the first couple of weeks, to make sure they don't go above 5. And here's the story comparing hydrochlorothiazide. Why did we get away from chlorothalidone? I'd like to tell you that every single study done, hypertensive studies with positive outcomes, is on chlorothalidone. We have those of you who like evidence-based medicine should never ever use a thiazide, because we have no evidence. From Allhead to Shep to Cyst Europe, you name the study and use chlorothalidone. Why did we get away from chlorothalidone? Is because we used 50 to 100 milligrams, and people got case of 2.8 and 2.9. So my favorite dose of chlorothalidone is 12.5. The drug works 70 some hours. It works at an eGFR of 30 or 35. Thiazides don't work when your kidney function is less than 40%. You get up to 8 millimeter lower pressures, lower albumin levels, and actually the outcome data are way in favor. So I'm not going to get into this in a moment. So one quick look about salt sensitivity. I wish we had a test. If you look at the entire US hypertensive population, all some 70 million or so, about 1 out of 2, half of them are salt sensitive. What does it mean? If you're salt sensitive and you take in more than 5-6 grams of sodium, and by the way, this going back, I always talk in terms of grams of sodium. The cardiologists use salt, they use sodium. So what's the relationship? It's 2.5. So if you multiply the sodium times 2.5, you get salt. And if you divide the salt by 2.5, you get sodium, okay? So this is a very easy way to go back and forth. We're not eating sodium, we're eating salt. So basically, that's the issue. But here comes something which is, if you are salt sensitive and you are hypertensive, and you take 8, 9, 10 grams of salt in, which a lot of Americans do. A full-size pizza is probably 10 grams of salt, just to give you an idea. Not that you hopefully eat the whole thing, but that's the amount of salt you're taking in. The number 1 source of salt in the United States, okay, according to CDC, is bread. Okay, and that's, people don't realize that. So if you ever had bread, if you ever had your congestive heart failure, people tell them to eat salt-free bread. It tastes like cardboard. It's just awful. So this is the salt issue. So if you are salt sensitive, you will raise your pressure. And you also regain some weight for a couple, 2-3 days. So here is an answer, because we don't have a good test how to measure who is and who isn't. Anytime you have an associated secondary cause, your EGFR is less than 60, you're African American, you have diabetes, and you're over 65, you're obese, and you use NSAID, you're salt sensitive. So interesting enough, the cardiologists know that for every decade after age 50, you and I get older, even if we are normotensive, we become automatically salt sensitive. So if you're about 80 years old, all of us are salt sensitive. So this is actually maybe Mother Nature's way to preserve volume when you get elderly. And here's the issue about we always think that African Americans are the ones who are the most salt sensitive. Wrong. It's the Asians. So here are hypertensives who have 140/90 or so untreated, and you give them 6 versus 9 grams of salt. You see the numbers there, or sodium. And there is a 5 millimeter difference in the Caucasians and almost double the rise in systolic. And of course, if you go to Japan or Korea and the Philippines, boy, do they love salt. And actually, if you look at those populations, they have a much higher incidence of strokes than in the US. There's something about the Asian predisposition to strokes from hypertension. So it's something already you know. So what's the issue? 80% is in the food, which when you dine out, you have no control over. The best test we have right now, and it's just a guesstimate, not a really reliable test, but it's actually pretty good, 80% accurate. So if you look at your triglycerides and divide them by HDL, which we all have readily available, and you happen to be hypertensive, if it's over 3, you're likely to be salt sensitive. So I find this to be a very helpful test. And here's something else that some people, when they read that they should be reducing their salt intake and they're totally healthy, well, don't mess with much Mother Nature, because if you're totally healthy and you have no disease and you cut down your sodium intake to less than 3 grams, there was actually increase in events in 7 years in 2 trials published in the JMA. So what happens to a healthy person who really restricts their salt intake? They stimulate the renal angiotensin system. So the angiotensin levels go up, and they probably get the negative effects from the active RAS system. So just if you reduce your salt, don't go overboard if you're normotensive. Just you stay in the 3 to 6 gram range, which is the middle of the road. Okay, so here comes my favorite. For those of you which cannot stay away from salt, please increase your potassium intake. Mother Nature's antidote to sodium intake is potassium. The average American diet consists of 75 milligrams of potassium. If you look at Mediterranean diets, okay, or you look at the famous DASH diet, they have double the amount of potassium in it. So if you eat a lot of fresh fruits or vegetables, you automatically double your potassium intake, and also, by the way, magnesium intake. And if you're hypertensive, going on a DASH diet lowered your pressure like 11/6/5, that is as good as 40 of lisinopril, 5 of amlodipine, and 12.5 of thiazide. So if you look at the power of increasing your potassium, it's as good as monotherapy. Okay, so just to give you an idea. Okay, NSAIDs are already covered, that they make the salt sensitive anybody in 3 to 4 days, and they reduce your EGFR. So if somebody has an EGFR of 50, I put them a week on an NSAID daily, their EGFR is going to be down to the 40s. So you lose about 10, 15, 20%. If you stop the NSAID, the EGFR goes back up. So it's functional, okay? But as you can see, you need to calculate if you use chronic NSAID, you know that they attenuate thiazides, beta blockers, ACE inhibitors, and the only drug which does not get affected is a calcium channel blocker. So this is an analysis from a couple days ago. They looked at the accomplished study from 2008, and they broke it down. Who did the best, diabetics versus non-diabetics? And the best outcome for the diabetics was less than 140. Not surprising. What surprised me is that when they were less than 130, they didn't do better. But if you drop them below 120, they were worse. So this is again, this is observed this is with somebody in the office taking your pressure, hopefully 3 times. Now in the non-diabetics, and that's really interesting, even with a doctor or the health nurse or healthcare provider there, the best outcome was less than 120, and not surprising, the lowest rate was for both groups with less than 120. And again, renal-wise, the best outcome was between 130 and 139. Worse when you're over 140. And what we see a lot, you take a hypertensive with an eGFR is 40 and you lower the pressure from 145 to 125, and the next thing you know, it's a bump up in the creatinine, and these are the studies too. So there's something about ideal blood pressure for people with eGFRs of 30-40% or less. They probably are best off to stay above 130. So that's what this study showed. So I'm going to leave you with the AHA, ACC, and ASH guidelines from November, which I think by now are outdated. Okay. And they will redo them for us in a couple of months. So basically, I think they're going to come down by about 5 to 10 millimeters. So probably get the 80-year-olds closer to 140, and get the second group with coronary artery disease and acute coronary syndrome and CHF maybe down to 130, and then get a whole group of them, the last group, in the mid-20s. So I don't think we go below 120, and again, these are observed pressure readings. So we're probably going to move 5 to 10 millimeters down, and you will find out whether I was correct with my prediction when the new guidelines come out. And again, for CKD, less than eGFR of 60, I think you should probably not go below 130 and stay around 130 to 135. And so there are some limits. Now, if somebody had a stroke, you should drive very hard to get as close to 120 or 125 as you can. Again, we need to really be very, very selective and individualize the treatment. Something which is lost, and again, the only ones who know this are usually the cardiologists. And there is a very nice rule. If you turn 60, don't lower the diastolic below 60. I think I remember that very well, because you have presumed coronary artery disease. You know that 90-some% of coronary blood flow happens in diastole, the only organ perfused in diastole. And so if you lower the pressure below 60, you may develop not just ischemia and angina, but there actually data to show there's a J-curve. There actually was a higher incidence of myocardial infarctions and cardiac events. So to summarize it, to what I wanted to bring in, so if you need 3 drugs, you must include the diuretic as one of the 3. And it should be, for most discussion, chlorthalidone at low doses. Please start to consider, for anybody, particular patients who have eGFRs of 60 or less and diabetics, to use all their drugs HS, or at least one of them HS. And I'm not going to harp on chlorthalidone one more time. We need to start to tailor our pressure readings to at least get some home blood pressure readings, so you know what truly the patient has. And if everything else fails, please consider low dose aldosterone from 12.5 3 times a week to 12.5 daily. And rarely do I use 25 milligrams. The only trouble with aldosterone is that you need to watch the potassium, and you need to have an eGFR over 30. Thank you very much.
Thank you, Dr. Mende. We have time for a few questions from the audience. Yes. Awesome. Stand up now.
Yeah. My question is, so we're being measured on our quality for hypertension. Are they using the in-office readings for those quality data?
Yes, I think the question was being judged on like an A1C, you're being judged on the blood pressure. So what reading are they going to use? I think for the time being, unfortunately, it's going to be the office, and because the office is higher, so you'll be doing better. From a standpoint of knowing what it is at home. But I think that I don't know. Hopefully somebody's going to go to the home readings, but it may be years off. So at this moment, unfortunately, it will be the office blood pressure. Okay, you may have to write home pressure in parentheses, and not increase somebody's blood pressure who's 140 in the office, 130 at home. But we'll see. Hopefully, it will get changed in the future.
Celebrex and Mobic have the same effect?
Yes, every single NSAID, no matter even the Celebrex, aspirin even in 8 to 10 per day, which very few people take, will not change your pressure. So aspirin and Tylenol have 0 effect on blood pressure. But every single NSAID, whether it's COX-2, whether it's from indomethacin to Celebrex, they all do the same.
I want to emphasize a point because I see this happening quite often, and I'll see what your take on it. We talked about the stage 2 hypertensive patient who has a blood pressure of more than 160 millimeters of mercury systolic. What I see often happening is the patient is put on monotherapy. Let's say they're put on amlodipine 5 milligrams. Now, the average blood pressure pill is going to reduce your systolic blood pressure about 10 points. That's average. So you're only going to go to about 150. But what providers then do is then when the patient comes back, they go to from 5 milligrams to 10 milligrams. You're not going to get another 10 millimeters of mercury reduction. You're only going to get another 4% or so. So you're better off going to another agent, a combination agent. So just one agent alone and then doubling it up doesn't double the number of reduction you're going to get on.
Yeah, I think that's a very, very good point. You can actually say that the numbers show that monotherapy, whether it's 5 amlodipine or 20 of lisinopril, if you double the dose, you get at the most, another 4 millimeters or 5 millimeters if you get lucky. So basically, you need to combine. Okay. And also with hypertension being multifactorial, all of us, if you do have hypertension, you have 2-3 systems overactive. You either retain salt, your RAS system is overactive. So by treating with one drug, you're only addressing one system. And then the other system, actually takes over more. So you actually, it's bypassing you. So it's better to have a moderate dose of 2 drugs than a big dose of one as far as the goal, getting to goal is concerned. Absolutely correct.
Just one more point. We said that blood pressure less than 120 before really there's no evidence that you need a blood pressure of less than 120. Sprint trial comes along this year and says lower it as low as you can. The highest risk patient is the diabetic patient, and we don't want it as low as what Sprint tells us. Why didn't they include diabetics in the Sprint trial?
Okay, because they said the diabetic trial was already done, which was the Accord. It's a government decision. And they decided that Accord already gave all the answers, and it said less than 120 with the Accord didn't show any benefits. But again, the less than 120 on the Sprint is you or mine 130 in the office. So this is, I mean, you should read the hypertensive literature. I mean, there are letters to the editors, editorials. I mean, the whole hypertensive society is up in arms because they're now fighting and said, okay, you really need to add 10 millimeters and don't tell everybody you got to go less than 120. It's actually 10 millimeters higher. So hopefully we go to the ASH meeting. I'll be in 3 weeks in New York for 4 days. So there all the committees are going to hammer out with the ACC and the AHA for the first time, all 3 together, and hopefully we'll get to observed or unobserved home pressures, office pressures, and clarify the whole area. So I basically think that right now, the take-home thing, if you get down to around 130, for most of the patients you and I see, that's a wonderful good target to shoot for.
Questions?
Yes, sir.
Diastolic you recommend for 70 and 80-year-old?
Diastolics? Yeah, I tell you what, again, it needs to be above 60. So let me just give you an example. An 80-year-old comes in, he has a blood pressure of 170 over 70, okay? 100 millimeter because of the stiff aorta and etc. So you start treating them and you get them down to 145, but now you're at 50, you need to back off. That's actually what the official recommendations are. So we really don't want anybody over age 60 to be diastolically below 60. I think that's a good rule.
Yes.
So this last year started a lot more people on chlorothalidone and hydrochlorothiazide thanks to this conference. Should we maybe be switching from metoprolol to the carvedilol since the risk of diabetes is so great with the other non-invasive dieters?
Well, see, it depends what you use to metoprolol. If you use, yes, I think the trouble with carvedilol is a BID drug. And if you look at statistics, people just always forget the second drug. But basically, if you can actually tell what happens to your patient. you do fasting glucose levels, and if they're over 100, you get an A1C. So if your A1C is over 5.6, so you have pre-diabetes, and at that person, just follow it. You put them on metoprolol for 2 years, and their glucose is fine, and the A1C is fine. Well, we probably can forget about that patient to switch over. But I want you to be aware of that 1 out of 4 will have a rise in fasting glucose and will have a rise of A1C, and that those, if you can, should be switched over as you make the diagnosis, because if we catch them early, it's totally reversible.
Yes, in the back.
Quick question with a suggestion. The sprint trial, were those wrist cuffs with arm on or
ARMS, all ARMS.
Now, with 38% of Americans currently reported as obese over age 20,
Right.
can you suggest to manufacturers that the large adult be the standard cuff
Right.
now?
I have the same problem. Okay, it's a very good question. Basically, what I need to prove to myself and you need to prove to your patient is the correlation. Those wrist things, in some people, the radial artery is really covered up and it's very deep. And so basically what I'm saying is if you get 140 or 130 with a wrist and 130 or 140, the same within 5 millimeters of your arm cuff, I'm totally happy. So you need to know what your relationship is between the wrist and the arm. But I know of no hypertensive trial which actually ever looked at wrist data. All the trials were done with arm cuffs.
Yes.
Are there recommendations for caffeine intake?
If you drink, if you never had a cup of coffee, and you take a couple of cups, your pressure goes up 4 or 5 millimeters for like 5-6 hours. If you drink 3, 4, 5 cups a day, you're immune to the effect. so basically, the good news is coffee is the only biologically free of side effects stimulus. So it's still a free lunch. Let's use the word.
But ideally, when you check the patient's pressure, it should be before they smoke,
Yes.
both feet on the ground, back support, before they smoke, before they have a cup of coffee.
Yes.
That's the ideal way of checking.
I think the smoking is, if you never ever smoked, and you take your pressure, I did this actually in medical school, and I smoked a half a cigarette. It made me actually pretty sick. My systolic went up by 18 millimeters. It is impressive. You have seen that too. Even in smokers, you go up 8 to 10 millimeters every time you smoke, even if you smoke a pack a day for the first hour or two. So it really kills the endothelium. You kill the vasodilation.
We have time for one more question if there's one.
I'll ask you something. What happened to the good old diuretic, amelioride?
Okay. Well, I tell you what, I still like it. I like it if you have people whose potassium goes down, so you combine it. It's a great drug if you, for example, can potentiate actually some calcium channel blockers. So the nephrologists will use it. It's the greatest drug for magnesium deficiency. It's the best magnesium retaining diuretic we have. It's better than aldactone, and we use it. But it's it's selective. So if you have somebody who doesn't want to take KCL and gets a low potassium because you're on loop diuretic, use 5 to 10 amiloride. Dirt cheap. It's a wonderful drug. And it lowers the pressure another 5 to 10 millimeters. Okay.
All right. Thank you, Dr. Mende.
Thank you.
Thank you.